warm welcome to you from Geneva, Switzerland. My name's Rada Satki, and I'm introducing and very pleased to introduce this special event on Serosurveys for vaccine-preventable diseases in the era of COVID. With me today is a distinguished panel. Starting from the top left is Simon Mutembo, Felicity Cutts, Carolina Danavaro, and Kyla Hayford. Welcome to all of you. We're going to talk about this topic of serosurveys specifically for vaccine-preventable diseases in the era of COVID-19. Now, there have been countries with recent serosurveys. Those include Cambodia, Vietnam, Zambia, Nigeria, Bhutan, the Democratic Republic of Congo, Mongolia, and Laos. So with our panel, we're going to explain and describe the value of serosurveys. We'll be talking with Felicity Cutts and then with Kyla Hayford about the study design and sampling. Be talking about how to conduct a serosurvey with Kyla, who's really serosurvey specialist. Serosurveys in the Ministry of Health, that will be with Simon Mutembo, and likely to be of interest to many of the participants. A global perspective with Carolina Danavaro from the World Health Organization, and then we will be saying something about SARS-CoV-2 specific serosurveys, even though our focus today is very much on vaccine-preventable diseases, and COVID-19 is not yet amongst them. So we'll be asking, of course, our panelists about the significance of the serosurveys in the pandemic. Now, before we go any further, I want to thank you because over 1,750 immunization and other health professionals registered for this special event. And where I'd like to start is actually with what you told us in the survey. 638 people responded to the survey, and I wanted to show you what you told us about what you know and what you want to know about serosurveys. So first of all, you can see the countries that had the greatest number of respondents were Nigeria, Ghana, India, Pakistan, and Kenya. But even if you were the only person responding from your country, we'd still like to thank you for having taken the time to share your perspective. Want to welcome people who are joining us on Facebook Live. So hello to Vishwas Anesti from India. And please tell us what city and country you are from if you're comfortable doing so. To Sheikh Raouf from Sheikhupura, Punjab, Pakistan. Taiwan Makip from the Democratic Republic of Congo. Ezekiel Danjuma, who says, happy to see Carolina's face again. I'm sure she will appreciate that. So let's go back to what you told us. So most of you who responded were in fact from a district, subnational, national level, so obviously from countries with a preponderance from a third of you coming from the districts. And of the group that answered, just a little bit over half had heard of the term serosurvey before the announcement for this special event. For those who knew, obviously, we then asked you if you're currently involved in a serosurvey or have plans to be involved in one in the coming 12 to 24 months. And 55% of you said that was, in fact, the case. 29% of you provided support or participated as a survey team member. 10% had substantial past experience with serosurveys. So we can be fairly confident that in this room we have with us people who are here to learn, but also people who are looking to share your experience. And in fact, for the group of 25, I think, or actually 36, who said they had substantial experience with serosurveys, most of you were involved with implementation and oversight, development of the protocol and serosurvey materials, and data management. Now, many of you seem to be involved in certainly more than one aspect. And we're not gonna review all of everything that you told us, but we did in order to prepare today's session. And you can see that here, most of you were interested in basic description of serosurvey, how and why they are used. So we're definitely going to go into that with the panel. So before we go any further, I'd like to ask each member of the panel to introduce themselves and to say a word, to comment. How did you interpret the results of this mini survey that we did with ahead of this special event? And is there anything that surprised you? So let's start with Felicity Cutts.
Thanks, Reda. So, hello everyone. Welcome. I'm not sure how much I was surprised because obviously people who responded to the survey probably were interested in Serosurveys, but it is good to see that there is such interest. There's a lot to discuss about them. I think their role is still not very well defined, and there are still a lot of challenges to overcome. We'll probably talk about some of that. But it's, I think this kind of event is new. It's certainly something new for me to participate in, and it'll be really helpful to see how this webinar can help gauge the interest and what kinds of things can be done to be most helpful to those of you out in the field. Thanks.
Great, thank you, Felicity. Kyla Hayford from the International Vaccine Access Center.
Hi, everyone. I was, like Felicity said, delighted to see the level of interest and the different types of jobs that you work in and how you take interest in Serosurveys. So it was great to see people who have had experience, but I'm very excited to be able to encourage and discuss how Serosurveys need to be interpreted if you're a policymaker, if you work in the EPI program and don't necessarily do them, but what can you learn from them?
Great, thank you. All right, let's go now to Simon Mutembo. You'll have to unmute yourself, of course.
I was a little bit surprised that the number of people responded to this. I've never participated in this. This is my first time. I was thinking it's going to be a small number, but there's a lot of interest out there on Serosurveys. So it would be very interesting to share some of the experiences from Zambia, as well as the experiences that I've gained working with different partners in doing Serosurveys.
Great. Before we go to Carolina De Navarro from WHO, I just want to acknowledge the participants on Facebook who are, and in Zoom. We just can't share your comments on screen unless you're on Facebook. Hanitra Rahan Tarisoa from Madagascar, who says, hello, everyone. And Dogubo Eladebi from Nigeria. Welcome, Edwin. We look forward to your questions, so you could just type your questions into comments if you're on Facebook, and if you're in Zoom, in that case, you can use the Q&A. I'm also keeping an eye on the chat as well, and encourage our panelists to do the same. So, Carolina, what surprised you, if anything? But before that, please do introduce yourself.
Hello, Carolina De Navarro. I'm a medical epidemiologist at WHO with the Global Immunization Monitoring Group, and really happy to see some of the friends from the scholar community. I think what doesn't cease to surprise me is the level of interest of people and how so many people are so eager to learn new things and share experiences. I was surprised to see more people than I expected with some experience doing Serosurveys, because they are not done that frequently and not for every disease. So we heard from some people who had been in HIV and others. So that was surprised me a little bit.
Great, thank you. Thank you to all of our panelists. Let's dive in on the value of Serosurveys. And we do have your question about the policy implications with examples that we're going to talk about. But before, I wanted to ask Felicity Cutts to share her experience of, how and why she became involved in these Serosurveys, and what was the first one that she was involved with? What happened? How did it turn out? We'd love to hear that story, Felicity.
Okay, so thanks again. So I'm going to reveal just how long I've been around for now, because my first Serosurvey was in 1987. I suspect half of you weren't even born. And it was in Mozambique. I think we have at least one person online from Mozambique, so very happy to see that. And in 1987, it was during there was a lot of conflict in Mozambique at the time, and we were doing a survey in Nampula city in the north of the country. And the survey was actually to try and estimate vaccine effectiveness of measles vaccine. And there had been recent guidelines from WHO on using cluster sample surveys and asking mothers about a history, had the child had measles or not, and comparing that maternal report of measles in the child among those who had received the vaccine and those who hadn't. And I was interested in how accurate the mother's report of measles was, and we decided to use serology to assess that. So the goal of the Ciro survey was to compare measles antibody prevalence in children with and without a history of measles, and among those who had no vaccination. So it was a cluster sample survey across the city. In those times, there was even without the conflict, there was very little communication. And what I remember is I was going to Kenya for a conference, and someone had come out from London bringing the microtainers, and we kind of handed over this box of supplies for me to take back to Mozambique. We used finger prick blood samples and collected just a milliliter of blood in the microtainer. There was really no lab. I think we probably even took a centrifuge with us, and we were out all day in the heat in the field, and in the evening centrifuging the samples and pipetting the serum off into a separate microtainer to freeze, and then ultimately managed to transport the serum back to London for assay by actually a neutralization assay. And the study showed that the mother's history, it wasn't bad. I mean, actually, most of the cases reported by the mothers were measles, but in terms of estimating vaccine effectiveness, there were too many false positive reports of measles for that particular method to be used. So we met our survey objectives. The survey, we had very good participation, very good acceptance from people from the community, and so it was quite a positive experience. Subsequently, I worked more on measles and rubella serosurveys in Ethiopia and India, where the main objective was to estimate the burden of rubella. But we also looked at measles seroprevalence. So I think that's probably enough for me.
All right, thank you. Can you give us a clear, simple definition of an immunity gap?
So in principle, it's clear and simple, but in practice, it's anything but simple. In terms of vaccine-preventable diseases, the aim for most vaccines, I would say for vaccines that provide lifelong immunity and that aim to reduce transmission of the virus or bacteria in the community, then the aim is to achieve a high enough level of immunity in the population so that transmission is reduced to very low levels or even eradicated, as is the aim for polio, and potentially one day might be the aim for measles. I might just add that is not the case for necessarily all vaccine preventable diseases, that you're not necessarily aiming to get this herd immunity. So when we talk about immunity gaps, we're usually talking at a population level, and we're trying to identify where there are the most people susceptible to infection so that we can try and target vaccination towards those people. And that might be a geographic clustering of susceptibles, it might be by age, it might be according to certain socioeconomic characteristics. So that's what we mean when we talk about an immunity gap.
Thank you. We have a first question from Mohammed, who says, considering the previous method of surveillance, how effective in terms of logistics and equipment is Serosurvey achievable? So let's go. I'm going to see if we can get Mohammed on the line so we can meet him and better understand the context for that question. Mohammed, are you able to speak to us? I have requested for you to unmute. We'd love to know who you are, where you work, before the panel answers your question. Welcome.
Hello.
We hear you loud and clear. Please go ahead.
Yes, my name is Mohammed Ahmed from Kenya. I am working with a co-group polio project in Mandera County of northern part of Kenya. From where I live currently, we are over 1,000 kilometers away from Nairobi, headquarters of the headquarters. So our sample, normally they do, they collected samples from Mandera, which is almost 1,000 kilometers away from Nairobi, send it to Nairobi, and then wait for the results. So comparing that, logistical challenges, how effective will now Serosurvey be done? Because even that at that level, the ordinary level, we haven't achieved yet, because at our county where I am now, we have to send the samples over 1,000 kilometers on the road to get the results.
Thank you, Mohammed. Who on the panel would like to? Yes, Kyla Hayford, please go ahead.
Hi, Mohammed. This is a very important point, and many people are experiencing being as the distance and the implications of getting a sample from where you are to Nairobi. So a couple things to consider. It is a challenge for Serosurveys if you need to bring specimens back to the laboratory and maintain a cold chain. So I would consider if you're trying to test for a marker that can be tested on a dried blood spot and collected and stored, it's far easier. Some antigens, some vaccine-preventable diseases work well. They're validated assays for that. Others are not. So it really depends on what you're trying to do. But I think this is a general important question about how you get out into a community, collect the specimens, and then preserve them to get them and tested for a high-quality result.
Thank you, Kyla Hayford. So this question of logistics and the complexity of these types of surveys, I'm sure we're going to be coming back and getting back to that. Thank you so much, Mohammed, for being our first speaker with the panel. I see several hands raised. Let's go to Sila Sekuna and let's make this as interactive as we can. Sila Sekuna, I hope you have a specific, relevant question for us. I've asked you to unmute, Suresh Dalpath as well. So please go ahead and yes, Suresh, please tell us where you're connecting from, who you are and what you do. And then we'd love to hear your question or your comment. Obviously, if you have experience that you would like to share with Serosurveys, we'd love to hear it.
Hello.
Yes.
Am I audible?
Yes, loud and clear.
Yeah. Hi, Reda, and hi, all panelists. I just wanted to know what is the additional, what additional we will gain through the Ciro surveillance, because this is a very resource intensive exercise, and what benefit it will be giving to us over the coverage evaluation surveys, which are periodically done by different state government and partner agencies.
Okay, great question for the panel. I want to make sure we don't only talk about the resource requirements and do more of the explanation of what our Serosurvey is as well. But let's thank you, Suresh, for that question. Who in the panel would like to respond to that?
I can take that one.
Yeah.
You really have to consider the different objectives that the different tools have. And the objectives of the Serosurvey, it's different from the objective of a normal vaccination coverage survey or coverage evaluation survey. The Serosurveys, you're really trying to detect immunity levels in the population and really understand if people are protected or not, to what level as a population against the disease. For the vaccination coverage surveys, the objective is to know if people have been vaccinated. A Serosurvey will very unlikely to, it's not really, most of them don't differentiate between immunity due to disease from immunity that you develop from a vaccine. So because they are different objectives, Serosurveys tend to be done at a different frequency, usually less frequent. And now with new technologies, in terms of labs particularly, you can test for many more things. And there was a question in the chat about how you integrate with other non-vaccine preventable diseases. And we'll get to that, but there are techniques where one Serosurvey can allow you to test for many different immunity levels for different pathogens. So it's a different exercise, it's a different tool.
All right, thank you, Carolina. Let's now go to the study design and sampling. Now, there's a lot of detail in that set of issues. And so, I just want to get maybe a quick sort of overview from Kyla Hayford about, what are the study designs? What does that look like? What are, just very briefly, what are the issues around selecting the target population, the sample size? There's actually Haija Fana on Facebook who wants to know, what about the sample size of a survey? Is it based on the total population, or sample size will be given generally? If you could say a little bit about that, knowing that we'll be sharing lots of resources for people who want to deep dive after this event.
Thank you. So I think the issues to consider are what study designs are feasible. You can do a standalone Ciro survey where you design everything and you target your question of interest only. You can try to nest a Ciro survey in an existing Ciro survey, provided that the target population, the sample size all fits with your objectives. And that can be a great way to be more efficient. A third way is to use residual blood that's left over from a clinic. Now that's a more biased sample, and you might not be able to get as much information about those people. However, you can learn a lot from blood, from available blood, and you don't have to interact with the person, and which is really important right now when there are risks of going household to household during COVID-19. And then the last one is leveraging existing biorepositories, which is a great way to work with a high quality sample and be able to generate meaningful results from blood that's sitting in many people's freezers right now. Some things to consider for sample size. We usually base the sample size based on how precise of an estimate you want to generate. I want to know the seroprevalence for measles within plus or minus 5%, plus or minus 8%. And that's usually how it's done, though it all depends on your question. But it is, and then the other things to highlight are when you're trying to decide between how to set up a Ciro survey, there are many different ways to do it. And I would just advocate that when you think about it, to go through all the different characteristics of what you can access and what you need to answer. And I also want to highlight that our team at Johns Hopkins with Simon Mutembo are working on developing some really detailed modules about how to do Ciro surveys, about how to address some of these questions about sample size, target population. And so when we have that launched and ready to go, we will share it with you, and that can provide a lot of details.
Great, thanks Kyla. Hayford from the International Vaccine Access Center. Let's talk now about the practical aspects, and this is again with Kyla, of conducting a Ciro survey. And before we go into the specific questions, can you tell us about your experience and with respect to a specific country or context, explain, give us a sense of how do you actually conduct a Ciro survey? What does that actually look like?
So I'll tell you a little bit about the steps of a Ciro survey by walking you through a household Ciro surveys that we have done in Zambia, that I've done with Simon as well as my partners at Johns Hopkins and in the Ministry of Health in Zambia. Like any study, you need a diverse team to do a Ciro survey, and this is especially true for Ciro surveys. So just thinking about it, when you go out into the field, before you go into the field, you need to be able to design the Ciro survey to answer the question that's important for the immunization program. And that's why when we started a Ciro survey in Zambia, just around the time of a measles and rubella vaccination campaign, we were grateful to have the policymakers and representatives from the immunization program involved in the design of the questions. And this has been really important. So in Zambia, at that time, the question was, after the campaign, what is the population immunity to measles and rubella after the campaign? Is the population immunity high enough to prevent large outbreaks? And are there remaining immunity gaps that need to be filled? So after we did determine that with our partners, then the epidemiologists on the team designed the study to be able to answer the question within the budget. And then you need to be able to, your field teams are the backbone of all of the work. And it's really important to highlight that they're going out and collecting a sample, a blood sample from healthy people, and how important it is to build relationships and trust with the community. And that's a key piece. Then you get your specimens, you bring them back to the laboratory, and you need an excellent laboratory team to test those specimens and generate accurate and reproducible antibody results. And then lastly, the data needs to be analyzed. And often it can be complex. As many of you know, with surveys from the Survey Scholar course, there's weighting, there are other issues to consider. So, so the data analyst teams are very important for generating the results and making sure those results answer the questions that originally were designed to be answered. So it becomes a big team. No single person can do it. But it's in Zambia, what we found was going through that whole process, what we learned after the campaign was that there was extremely high population immunity to measles and rubella, higher than even expected based on vaccination coverage alone. But we also discovered that the individuals just above the age group of the campaign eligibility, the campaign went up to age 15, and the individuals just older than that, there was a dip in seroprevalence to measles and rubella. And those are young adults and older children. And those are the ages that are really important for trying to prevent congenital rubella syndrome. So it was really an interesting thing that we revealed that we wouldn't have seen necessarily from vaccination coverage data.
Great, thank you. Comment from Felicity Cust to the attendees. For some antigens like measles, assays can be done on the oral fluid samples, but there has been a lot of variation in different studies as to how well the oral fluid assays work. Now, just a point of order, I've opened up the Q&A, so you can now look at the questions if you are participating in Zoom and vote for the ones that are of greatest interest to you. I do see a question from Jamilu Yahaya Runka on Facebook. And so I'm going to turn to the panel with his question. So the question is, how would you deal with confounders such as maternal immunity, antibodies acquired from the mother? Yep. I'm going to turn to Kyla unless, yes.
I think so. Generally, we're interested in knowing overall population immunity, and we tend to be directly linking it to the immunization program. So we tend to focus on children 9 months and older, and not children who are less than 9 months. There can be interference by maternal immunity in those younger age groups. Important to consider. You can include it in your model, but we tend not to focus on children younger than that age group.
All right, thank you. All right, a couple of questions about about conducting a serosurvey before we go on to serosurveys in the Ministry of Health with our panelist Simon Mutembo. So, Kyla, what can go wrong with a serosurvey? What's the worst case scenario? And I do have a question about serosurveys with respect to vaccine hesitancy. I'm going to save that for last, but what can go wrong?
Well, in any stage of immunization of the serosurvey, things can go wrong, as everyone knows. I won't focus on the war stories, but I'll focus more on what are the things that really matter and need to go right. One thing that's very important is ensuring that you have, try to reduce your refusal and non-availability rates. So if you're trying to get a representative sample, you need a high representation of people. And some people don't want their blood collected. So building trust with the community to try to prevent concerns and fears about it is really helpful for generating a high quality, meaningful representative result. And then the second thing that can go wrong, we've seen, is that that the assay that you're using, the test that you're using for antibodies, in the case of measles and rubella, you have to make sure it's adequately validated for your purposes, and also that the lab that's doing it is generating valid results. So I have to underscore that people are often trying new assays. They're very important. This is a highly evolving field, but always just remember we want to get high quality, valid results so that we can make sense of the data coming out.
Great, thanks, Kyla. All right, we have a question from Ahmed Navid Nusrat, and I've been asking him to unmute, but he may not be able to speak to us right now. But his question has received 17 votes in the Zoom room where we are holding this special event. Ahmed says, "What will the strategy be for training the existing staff regarding serosurveys, specifically in rural areas. So I don't think we're going to be able to hear about the context for Ahmed that led him to ask this question, but I'd like to turn to the panel for an answer or some considerations. And I suggest, I'm not sure who is best placed to address the issue of training in the panel, so I'll let you. Yeah, looks like Carolina. Yeah, Simon?
Yeah.
Yes, I am Ahmed Naveed Nusrat from Punjab, Pakistan. Actually, I am discussing the scenario, the question in my existing scenario. Here there is we have a very insufficient logistics and all other things in all areas, and also insufficient the human resource. And we have managed very toughly the all types of taking the samples for using the existing staff. So what will be the strategy we can adopt for existing staff? How we will get them trained for taking the Ciro surveys in a very well enough manner, and we get the ultimately a good results from Ciro surveys. Thank you so much.
Thank you, Ahmed Naveed Nusrat. I'm glad you were able to, we could hear from you today. So who on the panel? I believe Simon was about to answer. Yeah.
Yeah. So Ahmed is asking about training for staff working in the rural areas. I think that is very important to consider, because when you're doing Ciro surveys, you have people working at different levels. There are those working at the national level, the provincial level, you may go down to the district level. And most importantly, it's the people who work at the facility level in the rural areas and also in the urban settings. So you need to build capacity in those working at the lowest levels, because they are the ones who firstly are able to engage the community. Secondly, they are the ones who are able to go out in the field and collect the specimens. So training for those can take different forms. In most low-income countries, of course, you cannot conduct training for health center staff in the rural areas using internet. So you must have a plan to conduct on-site training for them. And Kyle has already mentioned one of the strategies you may want to start thinking about in conducting serosurveys, depending on the antigen, is to consider things like using or training them on how to collect dry blood spots, how to store them, and how to do the transportation. So the plan for training those in the rural areas should depend on the project that you are planning to do at that time and how you are going to engage the community.
Thank you, Simon. Any further comments on this issue of the reality of field-based training for a Ciro survey? Otherwise, we have a question. We have several questions waiting for us in both Facebook and Zoom. So, a question from Daniel Aduasomaning, who is the scholar team leader from Ghana, who asks: is it advisable to use rapid diagnostic test kits for Ciro surveys? Felicity?
I'll have a go at answering that. I think a rapid diagnostic test kit is for diagnosis of disease, and often that will be by measuring IgM, which is the antibody that develops most quickly after disease, but also doesn't last very long. So, for example, in the case of measles, IgM will develop and be detectable peaking between 2 and 4 weeks after infection. So if you detect IgM, then it's one way to confirm measles infection. But say by 3 months after infection, the IgM is very low or undetectable. And there are rapid diagnostic assays available for measles. In fact, there's a point of care assay available that is under field trials at the moment, and there's it's undergoing development commercially, so that hopefully that will become available and would greatly help laboratory surveillance of measles disease, of cases of measles in countries where transport to labs is a problem. But for Ciro surveys, we're usually almost always talking about detecting IgG, which is a longer lasting antibody, and it's unusual for rapid tests to be available. It's feasible. There has been some work done again for measles. In fact, it is feasible to develop a point of care assay for measles IgG that could be used in serosurveys. The problem is it's not really commercially viable. So at the moment, that work is kind of on hold. I think in HIV it might be a different story, but then in HIV you're really the whole system is quite different. So for the vaccine-preventable diseases, I don't think at the moment there are rapid assays to measure antibody that can be used in serosurveys, to measure IgG antibody for serosurveys.
Thank you, Felicity. I spotted a comment in the chat from Ibrahim EPI, who says, "I think such a survey requires a robust community engagement and social mobilization in the communities prior to the intervention." I've asked Ibrahim if he could tell us more about what's led him to this thought that he shared. He hasn't been able to unmute himself now. I take note of Abraham Amina Noor, who is having network challenges. And yes, let me reassure you, Abraham, this will be recorded. And of course, actually, the recording will be instantly available on Facebook. And then tomorrow will be shared with everyone who had registered for this special event. We know what the challenges are. You'll also be able to download the video file so you can watch it offline and don't have to pay to stream it. One more comment. Which takes us back to, and then we'll move to the Ministry of Health context for serosurveys. So Kolawole Salami says, do you think using this approach to assess vaccine coverage is a cost-effective venture for resource-constrained settings like sub-Saharan Africa? And I believe that was like the first question that was asked today. We want to come back to that. Kyla, could you lead us through and I'm sure Carolina will have something to say from the WHO perspective as well on this issue. What's the sort of cost benefits, cost effectiveness analysis, and what's the answer to what must be a recurring question you have heard many times before?
Yeah, I'll start. And yes, serosurveys are expensive to conduct, and the cost ranges substantially depending on the study design. But as you can imagine, just the supplies and the testing do add costs. So we're really working to better understand what's the cost and then to understand for what benefit. But it's also a very difficult question to say, what are you trying to learn? What is the value of the information that you're generating? So this is a fascinating area to work in. An interesting finding from Zambia and India studies that we work on is that when you go out into the field to do a household serosurvey, the largest cost of the serosurvey is getting out and doing the core survey component. The staff, transportation, data collection tools, and then adding the specimen collection on and the testing does add cost. In Zambia, I think it was about 36% of the cost was the specimen testing and cost. But again, if you can find ways to make it more efficient, then you can save a lot of costs. And what we recommend generally is nest, leverage, or integrate. So by nesting, this is what we did in Zambia, you nest your serosurvey with an existing survey, save on a lot of those costs. Leverage would be leveraging an existing biorepository or specimens that are already available, making your field costs nil. And then lastly, integrating. And this is if you can test more than one marker, there are lots of really good multiplexed assays that are generated, that are coming out right now, where you can test dozens of markers. It doesn't save cost, but what it does is it saves the value, the cost per marker tested goes down a lot, and you add a lot of value across the ministry's interests.
All right, 3 quick questions. The first one from, I hope these can have sort of concise answers. One from Aditya Mohapatra on Facebook, who says, "What is the ideal time for serosurvey after vaccination in a child, specifically with measles?"
That's a great question. I'm sorry, Raider, it's not that quick, because one of the challenges that we face with many of the vaccine-preventable diseases is that the antibody levels wane over time. And depending on the assay that you use, if you do a survey many years after vaccination, you may get a negative reading on your assay, whereas in fact the child is still protected because they have very low levels of antibody, but they also have cell-mediated immunity. And the antibody that they have, even though it's low level, it's high quality, so that on re-exposure to infection, they would mount a very rapid immune response. And so the longer, for something like measles, where antibody levels wane, especially if they're not in an area with endemic measles, they're not repeatedly being exposed. So they wane to low levels over time. And the assays, like many of the ELISA assays that are easy to use in a field survey, are not necessarily very sensitive. Then you have a risk of misclassifying children as being susceptible when in fact they were protected. If the aim of your survey is to determine whether the vaccine was immunogenic in the first place, then I would say, typically we would study between 1 month and 3 months after vaccination to assess the response to vaccination. But that's fairly unusual to do. It's really only done in a research setting. For example, I've seen people talking about vaccinating at age 6 months. So if you want to change the age for vaccination and assess whether the vaccine has been effective in a different age group, you might do a small survey in that setting.
All right. 2 more questions. One is from Vanesh Mathur, and it's gotten 14 votes in Zoom. Can we also detect immunity through other body fluids, so not blood, but say saliva, to make it easier? And Zarabruk Veres asks, what is the difference between Serosurvey and Serosurveillance?
I can start. In terms of the specimen, yes, there are examples where oral fluid has IgG antibodies, and it can be a proxy or an alternative to blood. However, it is a more dilute and variable specimen and can be difficult to make sense of the results. So I would caution about using oral fluid, except in the cases of some really robust examples like HIV for testing. And actually there is some early evidence of saliva testing for antibodies to SARS-CoV-2. Again, it's a new area. I can't advocate it, but something to keep an eye out for. And then in response to Serosurveys versus Serosurveillance, it's an important distinction. Serosurveys would be actually going out and doing a survey, and with the aim of estimating population immunity or exposure, whereas serosurveillance is often more of an ongoing system where just like surveillance for other diseases, you're trying to measure changes over time. You might be using a less representative sample, like from a sentinel clinic, to monitor exposure to vaccine-preventable or other diseases.
All right, thank you, Kyla Hayford. All right, we're going to try to. This time we're going to talk about the Ministry of Health. Lizzie Igmaid on Facebook has asked, who is supposed to be in charge of coordinating a Serosurvey? Which department will lead, and how is civil society involved? So let's go to Simon Mutembo. Warm welcome. You're also from IVAC, along with Kyla Hayford. Let's dive in. Who is supposed to be in charge of coordinating such what sounds like a complex, resource-intensive process?
Yeah, that's a very great question. Yeah, the conduct of Serosurvey is very complex. It requires a multidisciplinary team. It requires people from the research world who are able to develop the protocols, go into the details of sampling and all the mathematics that go with it. Then it requires involvement of the EPI because they understand what the needs for the Ministry of Health are, what the needs for the community are. then it also requires the involvement of other stakeholders within the EPI program. As two is supposed to lead the serosurveillance, the serosurveys, I think the best positioned persons are those who, of course, are familiar with how the conduct of surveys and the conduct of serosurveys, to be specific. But the EPI manager has a very big role to play in the conduct of vaccine-preventable serosurveys, because when conducting the serosurveys, you must have a lot of people on board. For most low-income countries, you probably must have the Ministry of Health on board. You must have the subnational levels of the Ministry on board. Then you must have the community involved, and the EPI program manager has the access to all those units. So they play a very big role in terms of community engagement, as well as bringing together all the stakeholders. But the science part of it may be very complex for the EPI manager because they've got other responsibilities that they're involved in. So you may want to leave the science aspect of the serosurvey to the experts in the field.
Thank you, Simon Mutembo. So you have worked with or in the Ministry of Health, and I'd love to hear that story. What led, can you tell us about it? When and where? What led to the decision to carry out a serosurvey? What were the challenges around issues such as engagement, the value and the resourcing and the dissemination? And of course, how did it turn out?
So I first became involved in serosurveys related to vaccine-preventable diseases in 2016 when I started working with Kyla and my colleagues at Johns Hopkins University. This was after Zambia introduced the first combined dose of measles and rubella in 2016. We wanted to look at the impact of the 2016 measles and rubella mass campaign after introducing the combined dose. It was a very interesting experience conducting a serosurvey in a country where it has never been done for vaccine-preventable diseases. We learned a lot of lessons. One of the major things which Kyla may have already talked about is we were able to capture additional information apart from the data that was captured for the post-coverage evaluation survey. When we added the serosurvey to the post-coverage evaluation survey, we were able to demonstrate that population immunity was actually higher than the coverage, vaccine coverage, which was being reported. The other interesting thing we were able to find out was that we were able to identify immunity gaps in the age group between 18 to 30, and those are women where we're supposed to have a higher immunity gap for rubella in order to prevent congenital rubella syndrome. Of course, conducting serosurveys in a low-income country like Zambia has got a lot of challenges. There's the cost aspect involved. Then there's the involvement, the engagement of the community. You must address a lot of those issues. I think we may stop there because we may have to go back to that.
Thank you, Simon. So, yeah, let's talk about that engagement. How best, in your experience, do you engage district and provincial health officers and then their communities themselves? They're obviously blood, many cultures is going to have a particular significance and meaning. And in practice, we'd love to hear how you have successfully engaged with these groups.
Yeah, collecting blood, especially outside the hospital vicinity, has got a lot of myths and a lot of challenges. So in engaging the community, it's a process which must be conducted at different levels. So you must have a buy-in from the highest level, that is from the national level. Then you must move to the subnational levels within those who are within the Ministry of Health and then the other stakeholders. But most importantly, in engaging the community, what matters is how you engage, starting from the district level. You must explain what you are doing in detail. They must understand. And then the district moving downwards must be understand and be ready to work with you. in most cases, you may have the guiding principles for engaging the community, but the plans of how you're going to implement it must be determined by the specific community that you're approaching. So you must have a very good plan where the district, when moving below the districts, are actually leading the actual sensitization, they're actually leading the process of talking to the community so that they are able to address the specific problems that community has, and they're able to address the myths around blood collection in the community. And the other thing that we learned in engaging the community in one of the surveys we did was we had gone to this community which was said to be a very difficult to engage community. In walking around the households as we were collecting blood, we didn't have a lot of challenges. So we had to ask them, why are you letting us collect the blood? And they were able to say, oh, we know those people that you are moving with. So in that community, what we did was, although we had a team of nurses from the health facility, but the guy who was leading the process was someone who lives within that community, is a community health worker. And because they were able to identify someone, they were able to let us in. But there have been other communities where you would go and things will not go well, but I'll concentrate on where things went well.
Great, thank you so much, Simon Mutembo, for this this country-specific experience. I want to go now to Carolina Da Navarro from the World Health Organization, and to ask you, Carolina, about the global perspective. So, in preparing this special event, we heard back from immunization professionals who express sometimes strongly worded skepticism about the value of serosurveys for a vaccine-preventable disease surveillance, given their costs and complexity. And we've heard several questions here. So what is the WHO perspective on serosurveys? When should they be conducted? And then there's a couple of other questions we'd love to hear from you about.
Thank you. I think it has been said here, but it really depends on the question, and serosurveys are just a tool to answer some questions. They are rarely used in isolation. So they, as you heard here, they are usually used with a survey to understand, for example, if a vaccine has worked. They have been used to understand in some research to understand a particular question about a certain new vaccine or new schedule or a different age group. And so WHO has guidance specifically where they explain everything about serosurveys for measles. It was put out last year. It's on the website. Dengue, hepatitis B. However, the role of serosurveys as how you fit it along with all the other tools, there was a SAGE recommendation of the Strategic Advisory Group of Experts last year that we need to do more to better clarify the use cases of different serosurveys, and also how they can be combined, particularly now that some of the laboratory techniques allow you to test a small amount of blood, either in a dry paper, the filter paper, or serum for multiple things, so that the investment, it's more gives you more for your money by looking at different diseases. And as it was said here, that requires a lot of collaboration, a lot of planning, because the worst that can happen is that you don't plan properly and then it's a failure and you wasted a lot of money and you got, for example, a very biased sample, or something went terribly wrong in the lab with the processing, or the test even used, it was not really the right test to detect immunity at a population level. Or what happens sometimes is that the results come 2 years later and you don't know what to do with those results because it's too late to make them actionable. So from the WHO perspective, just to recap, we have a specific guidance for selected vaccine-preventable diseases, but we need to do more about defining the role. And it really depends on each country when they are planning one of these needs to take into account the objective and how it can be combined to make it more efficient. For CRS, I'm reading in the chat congenital rubella syndrome. So basically, when the mother gets rubella and it's transmitted to the unborn baby. So you have to identify. I mean, in for example, in the Americas, some serosurveys were done with existing blood. So something that Kyla mentioned, when at least from blood that it was already collected, you were able to test for rubella antigens among women of childbearing age, for example. And with that, you have an idea from what age range people are mostly immune, and to decide on whether you need to do a campaign for rubella up to a certain age. I don't know if anybody wants to add something to the rubella part. Thank you.
So we actually have, let's see, Dr. Nida Ali, who says he has a success story of a serosurvey that sheds light on its significance and who'd like to share that. So as we have only a few minutes left, I suggest we go to Nida Ali. And then I also spotted a question from Martha Saboya for the panelists. So I'm hoping we'll have time for that. But I've already shown on screen some of the resources available. We keep these short because we know you are busy. And if you'd like to know more, there are many ways to deep dive, and we'll ask the panelists what their suggested ways are. So let me see what just happened to Nida Ali. Let me just ask Dr. Ali to unmute. Yes.
Yeah, hi.
Yes, hello and welcome. So we'd love to hear, you said a success story. That's the kind of story we like in immunization. Please go ahead.
Yeah, thank you. So there was this Ciro survey. It was actually a randomized controlled trial that was done in Karachi. It was the time when we were switching from trivalent oral polio vaccine to bivalent polio vaccine. That is, it means that we had made a polio vaccine without type 2 virus because type 2 had been eradicated by then. 1 year had passed and the Ciro survey showed that we had an increasing cohort of young children who had no immunity to type 2 virus. So this study predicted that, in future, without any mucosal immunity for type 2 virus, we may have an outbreak of circulating vaccine-derived poliovirus. Now, this study was conducted in 2017, and in 2019, we actually did have cases of circulating vaccine-derived polioviruses, 22 cases to be precise in 2019. And even now in polio-endemic countries, as well as other countries that have eradicated polio, we have CVDPV2 as a very big concern. So this study did actually predict, the Ciro survey did predict that immunity is waning, and we have a big cohort of children who do not have any mucosal immunity. So this was significant. Yeah, that's all. Thank you.
Great, thank you, Dr. Ali. Comments from the panel, and then we'll take one last question. We'll hear from Martha Saboya with her question before we close this special event.
That is a great success story, and there are other examples also. Madagascar illustrated there were major gaps in immunity to measles, and unfortunately it did predict a large measles outbreak that subsequently happened there. It would have been ideal to be able to fill that immunity gap before the outbreak.
Just to add to that, it's not just low-income countries where that happened. The same thing happened in Europe. In Europe, there's a network of serosurveillance, and 2008 they predicted a resurgence in many countries, but the countries did not intervene, and lo and behold, we had that resurgence. So I think it's part of the whole process of deciding whether it's worth doing a serosurvey is you really need to have the links to be sure that somebody's going to act on the information. Even if you do everything right, if everything goes well, you get rigorous, solid information, somebody has to act on it.
Great, thank you. Let's now go to Martha Saboya. Martha, I'm asking you to unmute, and I know you're ready. Welcome, Martha. We'd love to hear from you.
Thank you so much. Yes, I'm working for the Pan American Health Organization, and we are trying to increase the capacities in the region to use multiplex platforms as a way to survey from the serological perspective several communicable diseases, including vaccine-preventable diseases. So taking into account that immunizations have a really good experience around the world using serology as part of the surveillance, how we can accelerate from the perspective of immunizations, the integration of serosurveys for not only measles, rubella, and other VPDs. I guess that Kila and Carolina, you have mentioned several times that one way not only to reduce costs, but to gain more information to help countries to make better decisions, especially where we have weak surveillance systems. Immunology, immunoprofiles can be the way to fill all those gaps that we have, how we can take advantage of your experience to accelerate the integration of Serosurveys. Thank you.
I'm going to try to take this call because I think it's really important from our level here as to how we can start again coordinating more, so we are more aware of when things are going to happen in different regions, in different countries, so we can identify the points of integration and collaboration and start early, because it tends to happen that by the time you find out somebody else is going to be doing something, it's a little late. It's too advanced in the process, etc. So probably at all levels to try to have in mind that now, particularly with the technologies we have, particularly lab technologies and the multiplex assays, it can be more integrated. So I would say let's keep information flowing and trying to think outside of just immunization for us, and also collaborate more with the polio program that is doing a lot of surveys, Serosurveys, for example. And maybe Meseret in the chat was putting that Namibia, there was a very successful experience with an HIV survey linking it to Rubella, for example. And there are examples, but they should become the norm. And we can all, who are in this webinar, really try to contribute to whenever you hear about the possibility of integration, try to bring the people together. Thank you.
Great, thanks, Carolina. I know we are over time, actually, but it feels important to hear from Ibrahim Mohammed. So I hope the panel is able to stay, so we can hear from him. He says, "I was privileged to be part of teams conducting Serosurveys in Nigeria on polio, precisely in Sokoto State. Engaging the community is a difficult task, convincing them to be part of the survey, and so on." So let's hear firsthand from him. I know he was able to unmute a couple of minutes ago, so I hope his connection will be the story to close this special event. Ibrahim Mohammed, I'm asking you to unmute. I know you had unmuted before, so please, if you can do exactly the same thing that you did before, we would love to hear from you.
Thank you very much, and hello everyone. I'm Ibrahim Mohammed. I was opportune to be working in the immunization program. Precisely, I'm the technical assistant on State Emergency Routine Immunization Coordination Center here in Sokoto. Acceptance the immunization in the north, especially in Nigeria, is one difficult task. We have been pushing for people to accept this immunization. But one thing also, when it comes to research such as Serosurvey, you will find out that you need to enlighten people so much about it. They will think otherwise you are bringing something different, taking blood samples from their children.
I think we just lost Ibrahim's connection. His point was clear, though, and I would suggest...
It's one difficult task. You need to work very hard to take the ethical... Yeah, so that's very difficult, but I think working together and educating us more on how to conduct this research base will improve in conducting such kind of researches, because it has been very difficult involving people in Sokoto State collecting samples from their children, either in the community or the facility base. You have to use a lot of pluses to attract children and all the wards. So it's one difficult task. Actually, we need to work around the community involvement and enlightenment. Thank you very much, and over.
Great, thank you very much.
Quickly respond to that.
Yes, please.
Yeah, I think one of the strategies in engaging the community in things like Serosurveys or things which involve collecting blood or specimens in the community is to involve the community leaders or the community itself at a very early stage in the planning, so that they are part of it, they understand what's going on, they are able to speak for you, they are your ambassadors in the community. The trouble is most of the time Serosurveys or most of the studies are planned higher. Then at the end towards the end, that's when you involve the community. So starting early with the community would really help in addressing some of those issues.
Great, thank you very much, Simon. A lot to discuss here. We've barely scratched the surface. Obviously, this is one of the reasons why we asked you that question in the questionnaire. If you took it, we're grateful to tell us, would you be interested enough to take to sort of deepen your learning, engage in a course, perhaps in a scholar format, perhaps in other formats. I'd like to hear a final comment from each of the panelists, and then I'm going to tell you, for those of you who are able to stay over, I have something special because I'm going to be sharing a little bit of information about the COVID-19 Peer Hub that some of you already know about. So let's go back to the panel. Let's hear from first Simon, then Carolina, Kyla, and then Felicity to close this special event.
Thank you, Reda, for hosting me. It's been a great experience. What I would like to say is I think Serosurveys in most of the countries can be done, but the way forward is to consider integrating them with the other programs or other research projects that are going on. Like right now, there'll be a lot of maybe COVID-related Serosurveys. I think the EPI programs can start engaging if they've got plans to do Serosurveys on how they can ride on such kind of avenues. Like in Zambia, we've tried with Kaila Airport to use a biorepository which was collected for the population HIV impact assessment to do a serology for measles and rubella. Thank you.
Carolina? And you'll have
very
to
short. Happy to be here as usual with the survey with the scholars. Sorry, not survey scholars. Need a topic that I think is going to become more and more relevant because, as it was said, it's taking off already. Many countries are planning some sort of serology studies with COVID, and let's see what we can do. But again, most important message, if I can leave you with something, is be prepared to do something with the results.
Thank you, Carolina. Kyla, and then Felicity.
I want to advocate exactly what Carolina said. Be prepared to do something with the results. Make sure you know what your question is and then be prepared to share it. And I'm really delighted to see how much I learned in the chats today. Thank you very much. And I think as we continue to talk more and more about Serosurveys, we'll keep learning about how best they can be used and what's the added value for the immunization programs.
Thank you, Kyla, and Felicity for our closing word to this special event, if you will.
So just echoing what the other panelists have said, and thanks to everyone for your wonderful contributions and for giving the time. I know all of you are really overworked at present and under a great deal of stress, so it shows that this is something you care about, but yeah, you really need to be sure that the results can be used and acted on. And one of the things we haven't had time to talk about is actually the time that it takes to get the results. So we very much promote integration and the idea of the multiplex assays, things that could be done rapidly on the same platform without the need to store sera for years until they get analysed. Hopefully will make things a lot smoother in the future. But thanks again to everyone. It's all these scholar events, I come away invigorated by just how enthusiastic people are and what great work you're all doing. So congratulations to you all.
Thank you so much to the panelists and to the folks who got to speak, and to the many hundreds in the room. We know many of you will be watching the recording afterwards as well. So here's something special for those of you who have stayed all the way through, and that is, if you have not yet heard of the COVID-19 Peer Hub and you are an immunization professional, this is really something new that we are trying to do in response, just like everyone else, just like all the other partners, trying to figure out how to be useful to those of you who are working in countries to share experience, spread ideas, and to take action, perhaps faster, hopefully faster and better than ever before, to keep vaccination going during the pandemic. So you'll find you can apply now, right after this special event, if you haven't already. Applications will be accepted until the 26th of July. So you see, you have just 9 days and 5 hours to actually apply to join the Peer Hub. This will connect you to 15,000 immunization staff from 90 countries. If you are involved in COVID response and you are interested in supporting your immunization colleagues, your application will also be considered. So there's a lot of information about what we'll be offering through the Peer Hub. So I invite you to go and have a look. We'll be sharing the link with everyone who was registered for the event. Once again, a great warm thank you to the panelists for having raised this important issue, to the International Vaccine Access Center for doing this with the Geneva Learning Foundation, and of course to all of you scholars and newcomers to the scholar community. We're hoping to provide more events like this one, both on specialized topics and always in response to your needs, and the trying to be supportive and directly so, as immediately and practically supportive as we can. Once again, thank you. Signing off from Geneva, and look forward to staying in touch. Bye bye.